Funny. Morning. Can you hear me?
I can hear you.
Excellent. We've got Eric, and I saw Kimberly and Joel there.
Yep.
Okay. Harry, are we good to go? Or Katie, are we good to go?
Yes, we're good to go.
Okay, excellent. All right, folks, I think we have the technology mostly under control here. So we're going to go ahead and get started. I'd like to welcome you today to the Global Genes Rare Project webinar series. I think this is the third or fourth in their series for 2013. And today we're going to focus in on essential health care benefits. We're going to spend the next hour with some brief presentations and then hopefully a lot of conversation back and forth with all of you to answer some questions. I'm sure we'll get to all of them, but we will do the best that we can and continue to communicate afterwards. Briefly, first off, I wanted to thank our sponsors, Shire and Bayer. They're the primary sponsors for this event, and of course, there's some cost and background things, and we do appreciate what they do to make this webinar series possible. A couple of things, if any of you are having trouble hearing audio, you're seeing my face and perhaps the screen, you do need to call in using your phone. Everybody's using the same phone number and access code. And then for your attendee ID, if you know that, put it in, great. If you don't, just hit the pound sign and you'll come in. You'll be unidentified in our list of participants, but that's okay. You'll still be able to ask questions and participate. A couple of things about the way that the WebEx control panel works. We know this is not familiar to all of you. These are a couple of screen captures. Yours might look a little bit different than this, but I would encourage you to look at a couple of things. One, you probably have, if you can see my mouse, you have something up at the top of your desktop, which may or may not actually show on your screen right now, but something about a little green bar that might allow you to access some additional control panels. And you may have on the right-hand side of your screen also some control panels as well. We'll be using the chat window for our questions and answers, not the Q&A window. Use the chat, please. There's some technical problems with the Q&A. There are two ways that you can view what's going on with this webinar. One is what you're probably seeing right now is a desktop. And Eric, I guess we've got your cover slide in there, which is great. But you're seeing my desktop with this embedded in right now. And that will be where you see the PowerPoint slides. In a little pop-up window, you will see whoever is speaking in that pop-up window. If at any time you want to see just the speakers large, perhaps when we get to the Q&A, this icon up in the upper right-hand corner with the three heads, that's what you'll want to click on to bring to a full screen, which, which I don't have the picture of now, but basically you will get a full screen of just the talking heads. So with that, we'd like to get started with one of the features here, which is a poll. And remember, the poll questions will be probably on the right-hand side of your screen and one of those little pop-downs. Would you please, Katie, bring up the poll, and let's find out who we have in our audience today. And since I'm sharing my desktop, I actually, oh, there it does show up on my what I see or not, but could you take a quick click on that and note who you are? And we'll come back to that in just a moment, and we'll kind of report back to you what our mix of participants is. My understanding is that we have several hundred people online right now. I'd expect a lot of them to be advocacy and individuals, but I bet we've got some people from the research side as well. So let's keep that live for a couple of moments, Katie. My name is Dean Sir, and I am the president and co-founder of the MLD Foundation, and I'll be moderating today. I wanted to very briefly introduce you and then confuse you about the Affordable Care Act, and let you know, as you probably know already, that this is a very, very complicated document that drives what's happening with our health care right now. I pulled up some information from Wikipedia that I think will kind of put our toes into the water. First is this was signed into law in March of 2010, so almost 3 years ago, in fact, a little over 3 years ago. It's called formally the Patient Protection and Affordable Care Act. Obamacare, ACA, are kind of the short abbreviation. As you probably know, this act went to the Supreme Court. Most of the provisions were upheld last year when they ruled. This document is just shy of 1,000 pages, but if you know what the law looks like and you've ever looked at some of that, 1,000 pages can probably seem like 10,000. And it phases in from 2010 through 2020, with 2014, January 2014, and actually the latter part of 2013 being a very key date, because this is when the insurance provisions really start to kick in that I think many of us will see. And Wikipedia describes this as the most significant government expansion and regulatory overhaul of the healthcare system since Medicaid and Medicare in 1965. The next slide is probably, sorry, we'll get to the final slide in a moment. The primary purposes of the ACA is to increase the rate of health insurance coverage, reduce overall costs, and provide a number of mechanisms to increase the participation in the coverage. It also has some provisions to improve healthcare outcomes and streamline the delivery of healthcare. So this is a very, very broad act. I listed on this page some of the rules and regulations or areas that we'll be dabbling in with the ACA, and everything from insurance exchanges. You may have heard a bit about those. We're going to dig into that just a little bit today. The mandates, the subsidies, the eligibility, lifetime caps, kids being able to stay on until age 26 on their parents' policies, some issues with guaranteed issuance and premium leveling, issues that have to do with pre-existing conditions, and then minimum standards for what health insurance covers, and co-payments, co-insurance, and some things that are called essential benefits. And this is what we're going to focus in on today. We'll touch on some of those other issues, and our experts from DC, who I'll introduce to you in just a moment here, will really dig into this in more detail. But as you can tell, the ACA is a very, very complicated and broad act. So it's really important that you, as advocacy groups particularly, but also as individuals that might be participating in one way or another with health insurance, that you become well informed. And we hope that today that you will learn a bit about this, and we're going to have some time to ask questions. Katie, if you want to finish up with the poll, show what those results are, and then we'll get our speakers going. Katie, can you show us the results of the poll? I guess that'll pop up in a moment. Okay, well, let's get started with our presentations today. We have 3 people from, all from actually the East Coast and the DC area. And I'd like to introduce them to you very, very briefly, and then allow them, as they get into their remarks, to tell you a little bit more about their perspective and where they're involved in ACA and essential health benefits. Joel White is the president for the Council of Affordable Health Coverage. They do a lot of hands-on work with regulations and the people that put those regulations in effect in DC. A lot of advocacy and some lobbying there. I did put Jennifer Bernstein up there. I wasn't sure if Joel's going to make it this morning. Jen was his backup, but Jen works with him, and she's very handy if you have questions about some of the policies and bills as well. Eric Gascho from the National Health Council will be joining us as well. He works in their government affairs group, and he will dig into some of the real nitty-gritty of what's going on with essential health benefits. And then Kimberly Beer, Director of Advocacy from the Arthritis Foundation, is going to give us or share with us some of the success that they have had with actually impacting regulation and impacting the coverage that we get through the Affordable Care Act. So she's going to kind of wrap this into a package that lets you know how you can actually engage in this process, not only of learning what ACA is, but helping to refine how it works for all of us. And with that, I'd like to turn it over to Joel and let him take over. Joel, I'll be advancing your slides for you. And please introduce yourself briefly, and we'll take it from there. I can't switch the speakers, so can you do that?
Can you hear me now?
We can hear you now.
Okay, sorry about that. This is not a commercial for Verizon. My name is Joel White. I'm the Executive Director of the Council for Affordable Health Coverage. We are a group that came together in 2001 with a singular focus to promote affordability of coverage, just as our name implies. We are 21 very diverse organizations. We have patients, providers, employers, and payers are part of our organization, and we've spent a lot of the time dissecting the Affordable Care Act, reading through the regulations as they've come out, reading the statute, spent many a night falling asleep reading the statute. It's a hard read. But today I'm going to talk a little bit about what has come out on the regulatory side to implement the Affordable Care Act related to insurance exchanges and essential health benefits. You can go ahead. So the way I like to think about insurance exchanges is that they're kind of a shopping mall or a website that has multiple providers on it. And when you go into the mall, you basically see different stores. You might see a Kmart, and you might see a high-end store like a Nordstrom's or Brooks Brothers or something like that. And once you go into the mall and you decide which store you want to go to, you go into that store and you're able to select from the products there, and there's multiple products. And so insurance exchanges are going to operate very similarly. More than 20 million people may seek coverage through the exchanges by 2018. We're expecting 6 to 7 million people to sign up through these exchanges, these online marketplaces, as of January 1, 2014. The exchanges are supposed to be up and running, portals are supposed to be up and running so that people can start comparison shopping, making their selections in October of this year. If you're counting, that's just 5 short months away, and a lot of things have to come into place between now and October to ensure that people have an ability to comparison shop and enroll in health plans start for coverage to begin effective January 1, 2014. The law does standardize to a great degree the options that are available. So a suit at Brooks Brothers may look very similar to a suit at Kmart. Basically, you'll have choices between 4 different levels of coverage. They're metal levels. They're called bronze, silver, gold, and platinum. The difference at the bronze level is that the health plan has to pick up 60% of the costs, and the individual picks up 40%. On a platinum plan, the individual picks up 10% and the plan picks up 90%. So the platinum is a little more comprehensive, the bronze is a little less comprehensive, silver and gold are in between. Individuals who don't purchase coverage will be subject to a penalty. This is called the individual mandate. This is what the Supreme Court ruled on last year. The penalty starts out low and increases over time, and it's intended to provide an incentive for people to sign up for coverage. Businesses with 50 or more employees who don't offer affordable coverage will also have to pay a penalty if an individual receives a subsidy through the exchange. As I mentioned, open enrollment begins October 1st. Some states you will have a choice of obtaining coverage inside an exchange or outside an exchange. The big difference there is that in the exchange, if you're eligible for a subsidy, you can get one. If you purchase coverage outside of an exchange, even if you're eligible, even if your income is below 400% of poverty, you won't be able to get a subsidy. Which leads us to a discussion of cost. There's a lot of benefits associated with the Affordable Care Act. I was just on a panel with Secretary Sebelius. She's passionate about highlighting the benefits, but there are costs that come with this. And in general, to the extent that the benefits included in the plans are more comprehensive, more robust than are currently available or typically purchased on the market, people will pay more. What we're seeing is that nationwide about 32% increase in premiums. Each state will be different because of how the rating rules apply. About half a dozen states will see decreases on average in their premiums, but on average, nationwide, about a 32% increase. So the range is somewhere between a negative 22 to 169% increase. Again, that's going to vary state by state. Dean, you can go to the next slide. So again, exchanges will vary based on the availability of coverage. There's nothing forcing health insurers to offer plans on any of the exchanges, but we do expect that there will be robust participation by plans in all 50 states, and that that coverage will be largely available at all of the metal levels: bronze, silver, gold, and platinum. The number and the type of plans available on the exchanges, however, could vary very much, which makes that web portal available on October 1st for comparison shopping very important that gets it set up. Again, I said 23 million workers may receive coverage by 2018. As I mentioned, individuals with income up to 400% of poverty are eligible for subsidies. It's a sliding scale subsidy, so if you're at the lower end of the income scale, you'll get more of a subsidy, and it phases out at 400%. That's about $45,000 or so for an individual, about $85,000, $90,000 for a family. And for people who are currently in the PCIP or the federal high-risk pool, or if you're in a state-based high-risk pool, that coverage will begin to be transitioned out, and by 2014, most people will be in an exchange-based plan. The federal pool, the enrollment has been closed, and there's some legislative efforts in Congress to perhaps address that, to reopen the enrollment for the rest of the year. But all those that coverage option will begin to be phased out. You can go to the next slide. So on the essential health benefits side, so that's kind of where you get your coverage. On the essential health benefits side, that's kind of like what coverage do you buy. So I think the next speaker is going to get into more of the benefits side. On the cost sharing side, the policies that you buy, there will be an annual limit on cost sharing. For 2014, it's really going to be about $6,250 for an individual, about $12,500 for a family. Importantly, that limit on cost sharing does not apply to out-of-network services. So if you need to see a specialist, for example, who's not covered in network by your health plan, anything you spend on that provider does not count for the $6,250 or the $12,500. Only in-network spending counts. There is a concern that, you know, for folks with rare diseases, going out of network is kind of a regular part of life, and that would disproportionately impact those folks. And we agree. There is in the small group market a cap on deductibles. There's no corollary in the individual market or the large group market. So that cap is set at $2,000 for an individual, $4,000 for a family. The HHS just came out with their final rule on this, and they basically said if it's impossible for a health insurer to offer a plan at the bronze level, that they would waive the applicability of the cap. So we might see some variation around this, especially for small businesses in states where plans are having problems meeting that level of coverage. Can you go to the next one? Actuarial value, I kind of already went through this, but just real quickly, bronze, 60% needs to be covered, 40% gets picked up by the individual, all the way up to a platinum, which is 90-10. And there's allowed to be some variation here within 2 percentage points. The reason for doing that is to get more plans into the market around those various levels. Dean, you can go to the next slide. So I think that one of the issues that we want to make sure that you understand is that there is some confusion and concern about what the final rule says about coverage for access, particularly for prescription drugs. And plans are going to be recovered to cover at least the greater of one drug in every category or class in the USP, listed in the USP, or the same number of drugs in each category and class as a benchmark plans. And Eric's going to get into what those benchmarks are. Many of the treatments are not listed in the USP. The breadth of the benchmark formularies will definitely vary state by state, so this won't be uniform coverage. It's good to know that many state benchmark plans will require at least 2 drugs per class, but again, that won't be uniform across the state. We were hoping that there would be much more of a requirement towards the Part D side, so that that requires that plans would cover all or substantially all drugs in each class. It's a much wider formulary and allows for much greater access to those products. The nice thing, though, is that the final rule was an improvement over what was initially proposed, where HHS proposed only 1 drug per class. So I think we're making progress, and we're going to talk, I think, at the end about what we might be able to do to expand this even further. All right, you go ahead. So just to run through this really quickly, you know, we did ask that HHS ensure that patients would have access to all medically necessary drugs. Again, HHS decided to go with that greater of on the formulary. The other thing is that we wanted to ensure that there was a process for appealing formulary denials. Our hope is that we would get that notice out in a sub-regulatory document that everyone on this call could help us weigh in on. We also asked HHS to ensure that plans would cover new drugs that come on the market. There's no process that's really spelled out in the final rule, and we need to make sure that that's spelled out. And then finally, I know some had expressed concern that utilization management might result in specialty tiers or fail-first strategies. Obviously, those strategies don't work for people with very rare conditions, and so we're also watching and monitoring that, and we're hoping to weigh in very aggressively with HHS, and we'll get into how we're doing that in a little bit. Can you go to the next slide?
That's it.
Thank you. With that, I'll turn it over to Eric.
Excellent. Thank you, Joel. Let's see if we can get to Eric. All right. Next, we have Eric from the National Health Council.
All right. Can you guys hear me?
Yes. Thank you, Eric.
Okay. So thank you for that introduction, and thanks for having me here today. Quickly, I'll give you a overview of who we are at the National Health Council. We are a membership organization. Primarily, our key constituency are patient advocacy organizations that really run the gamut from higher prevalence diseases such as heart cancer and diabetes all the way down to a lot of rare disease organizations. Our members also include various members of the health community, such as pharmaceutical companies, healthcare providers, insurance companies, which really help us make sure that we have a wide perspective on these very complex issues, such as essential health benefits. So if we go to the next slide.
Clicking.
Okay.
Now I'm clicking. Let's see what happens here.
Okay. Well, I'll keep going. So what the statute for essential health benefits in the Affordable Care Act says is that all health plans must cover a certain level of health services and medications. But the actual detail that was included in the law is not very great. Essentially what it says is that all health plans have to offer a level of coverage that is similar to a typical employer health plan, and which can vary greatly. So a lot of the first questions that we had is what exactly is a typical employer plan? The other thing that the law said that the package would have to cover are these 10 categories that you see on this slide. A lot of them typically aren't covered by typical employer plans, so it's really taking these buckets and kind of filling in where there would still be gaps. So in the end of 2011, HHS put out a bulletin that kind of explained how the process would go for states to come up with their essential health benefits. Essentially what this plan is that each state is allowed to select what they call benchmarks, where you look at one health plan out of the various ones that are offered in their states as what they consider would be the basis for what other plans should cover. If states do not choose a benchmark, there is a default, which would be the small group plan that has the largest enrollment in their state. Go to the next slide. And Joel kind of touched on this already, that also requires that there would be certain cost-sharing restrictions. As he mentioned, this year that limit is $62.50. We expect that to be $64.50 for individuals. Next year it's still hasn't been decided yet. That's kind of what we're looking at. The other thing I'll mention here too is that the Department of Labor recently put out a statement that for 2014 only, certain group plans would be able to increase the cost sharing, the out-of-pocket limits. And this is something that the National Health Council vehemently has been opposing, and we're hoping that the department will reverse this decision. We sent a letter that was signed by 107 organizations that really run the gamut of patient organizations to oppose this decision. We're hoping that it'll be something that will be reversed. And as I kind of go on, I'll tell you what else we're looking at in terms of recommendations. Next slide. These next two, I'll go through really quickly. They just kind of show us where we are now. 16 states and DC have decided that they will operate their own exchanges. 6 have said they will do a partnership with the federal government, and the rest will be in what is called the federally facilitated exchange. So for the ones that have chosen not to establish their own healthcare exchange that Joel was describing, the federal government will then step in and establish an exchange for them. Go to the next slide. This shows where the states sort of fell with how they chose their benchmarks, which is what all other plans will have to follow in terms of essential health benefits. As you can see here, the vast majority of states are going to be using the small group plan. A lot of them were because they didn't actually choose what they would be going with, so the default was a small group plan. You'll see that a few of them used HMOs, which sort of created some unique circumstances. But also it's important to note on this slide that the asterisk shows that some of these small group plans were also HMOs. So we're really kind of starting to look through what exactly are in these in terms of the services that they provide and the depth and breadth of the formulary. Go to the next slide, please. So this slide just sort of highlights the work that the National Health Council has done on this issue. I think that even before the legislation was signed into law, we saw that this is going to be one of the really key issues that we need to be keenly focused on as we implement the Affordable Care Act. In fact, there were actually only 3 issues that came out of this incredibly large piece of legislation that we have really laser focused ourselves on to make sure that we're getting the best results for patients with chronic diseases and disabilities. We conducted a white paper that really talked about what exactly is essential health benefits, what was in legislation, what still has to be decided. But then did an actuarial analysis to look at how affordable a lot of these services are going to be and what this is going to do for the amount of money that people are going to have to pay. And what we ended up really figuring out, especially after they came out with the benchmark plan, is that there's going to be a lot of variation, and that's going to be very problematic and really means that we need to start monitoring how exactly the states are implementing this. So we put together a set of recommendations, which we'll see on the next slide. Because of all the variation, we really want to make sure that there are a certain level of patient protections in there that will make sure that patients are getting the services that they need. The first one was something that Joel mentioned, was medical necessity. We really want to make sure that plans have an established definition of what medically necessary is. In fact, we have been trying to encourage the federal government to come up with their own definition that would be uniform across all health plans. Barring that, we're hoping the states will do it, because we know that if we get down to the point where every plan has a different definition for this, it's going to be really problematic for a patient who is trying to appeal a coverage decision to figure out what exactly the process is to do this. So we're really hoping this will be done at a higher level than at the plan level. Similarly, anti-discrimination, the essential health benefits rule that came out just said that plans can't discriminate. What exactly does that mean? We're still not 100% sure. We're hoping to see more concrete definitions of what plans aren't allowed to do to discriminate against patients in sub-regulatory guidance. But we're really hoping this will be done at a federal level, which makes it much easier for folks to understand the process and advocate to make sure that we have the appropriate protections. Next, we have navigation services. Every health insurance exchange will have to establish a way for people to find the right plan for them. Depending on what condition you or your family member has, a plan might be better for you than it would for me, and vice versa. So we really want to make sure that there are the right people in place and the right processes in place so that someone can figure out which plan off of these insurance marketplaces works best for them. And finally, we're really encouraging the department to better explain how we're going to be overseeing plans. There will be some sort of shared responsibility between the federal government and the state governments to make sure that the different plans meet the various requirements of the essential health benefits and to make sure they're not discriminating against patients. So we're hoping to see that also come out in new guidance to make sure that we are doing the best job that we can to ensure that patients have adequate coverage. And with that, I guess we'll hand it over to Kim, and I look forward to taking any questions that you guys may have.
Okay, let me move on to Kim. And Kimberly Beer is the Director of Advocacy for the Arthritis Foundation. Kimberly, can you tell us a little bit about how your group has traversed these waters?
Sure. Good afternoon, everyone. Again, my name is Kimberly Beer, Director of Advocacy at the Arthritis Foundation. Today actually marks the beginning of Arthritis Month. We represent the 50 million Americans who have a form of arthritis, including 300,000 children and 1.4 million adults who have a form of juvenile arthritis. Would you mind advancing the slide? I'm sorry. I don't want to look down. Thank you. We have been extremely active, the Arthritis Foundation, in monitoring and submitting comments on ACA regulations on behalf of the patients we represent. We are an active member of the National Health Council, and we couldn't do this work, and so I'm not sure of those who are on the webinar who are currently participating or a member of a certain council like Joel's or Eric's, because we wouldn't have been able to manage traversing these waters without them, because it was so overwhelming and continues to be overwhelming. I have been working on this since the law has passed, and I just listened to both Eric and Joel, and I continue to learn new things. So this is not something that one masters and has every sort of angle worked out and figured out how they're going to, how I'm going to manage every single sort of aspect of it. So it continues to be a very overwhelming process, but with their help and sort of identifying key things that patient groups like the Arthritis Foundation has chosen to sort of focus on, and one of them, of course, was the process of the essential health benefits that Joel and Eric really summarized really well. And if you could advance the next slide, please. Well, I'll just continue. Joel and Eric talked about the bulletin that was in December of 2011, and there was a huge sort of outcry to the benchmark plan, offering the drug categories that was referenced in the bulletin, and HHS received 11,000 comments. I believe it was 11,000 comments received from the patient community in response to that one small sentence in the entire bulletin that was pre-regulatory. And while Joel mentioned that it wasn't completely ideal, it was much better in the final rule, and that was a direct, I believe, result of patient groups who are active and activated in sort of responding on an individual organization level as well as coalition level. So if your organization is not currently involved in a council or even a listserv, I highly recommend it, because we will now continue to have to monitor the essential health benefits as they get updated in 2 years. So these are not sort of set in stone. And I know sort of the next, they're a little bit out of order, and I know it's not related to the essential health benefits, but another kind of aspect that the Arthritis Foundation is concerned about and is monitoring as far as the ACA is concerned is the Prevention and Public Health Fund, which is a fund that was established, I'm sure as many of you know, as a way to provide mandatory funding for prevention programs. And of course, many of our diseases, there are programs and evidence-based programs that can help prevent diseases like arthritis or osteoarthritis. So we're very concerned in this funding. It was a huge amount of money, and a lot of it is being used to sort of fund other aspects of either HHS or other programs as offsets for some of the battles in Congress surrounding SGR. So every time it's sort of up for grabs as a way to offset other programs, we have engaged our grassroots, which are 65,000 members, and some of our top ambassadors to communicate with Congress on this issue. So it's just sort of another aspect of how we've been involved and how it's meaningful to our advocates and everyday people. And then again, finally, again, it's a little bit out of order, but we did also provide comments on the final rule on EHB, and we have particular interest, again, especially for individuals who have a form of inflammatory arthritis, prescription drug coverage. Immunological agents and immunosuppressants are sort of life-changing medications for people with RA, and we have to make sure that they have adequate coverage and access to these medicines. So not only can we want to make sure that the benchmarks cover it, but we want to make sure they can afford it. So the cost sharing, we're a little bit concerned about excessive cost sharing, specialty tiers, so we're closely monitoring that. And then, of course, access to specialists, the limits on certain services, wellness programs, and physician-administered drugs. A lot of, as you know, a lot of your organizations and patients you represent receive medications under, for instance, under Part B that are infused. And so the rule doesn't really talk about that, and we, of course, we're very concerned, and we kind of really enumerated that in our official comments. And then finally, what Eric mentioned regarding the recent Department of Labor letter, honestly, if the National Health Council hadn't been monitoring that, I'm not sure that I would have noticed that was sort of noted in the frequently asked questions. And that, again, is something that is particularly very concerning to our community, so we were really grateful for the opportunity to sign on with those other 107 organizations. Next slide, please. Now, it is, and again, I'm not sure I know the pop-up of what the level of knowledge is or engagement or understanding of the ACA is, but again, I have more resources than I know what to do with, but I kind of just wanted to highlight 3 that I think I use probably at least every day, if not several times a day. And so I just thought I would share those with you to sort of help monitor like the policy aspects of the ACA, but also to monitor the regulations that are coming out of HHS and all of the opportunities for organizations to participate in open forum phone calls and regional discussions. That's all at HHS's website. And so I highly recommend that, at the very least, you're signed up for a listserv through HHS if you aren't already. And a lot of the information that Eric shared on essential health benefits and the state exchanges, I manage and monitor through statereform.org at the National Academy for State Health Policy. And another great aspect of this website is that you can sign up as an individual and you will receive updates on what's happening in your state and what's being uploaded as far as pertinent information as it relates to the essential health benefits package or the benchmark plan and the exchanges. So it's still, again, when the bulletin came out and sort of put it in the state's hands, we were kind of thrown off a little bit and wondering how are we going to do this as an organization with 10 regions and share the information with the regions with the regions and to make sure that they have enough information. So we're still struggling with this, and again, we're going to be working with the National Health Council to help us create a template for information that we can put on our national webpage and share with our 10 regions to do outreach as far as helping people understand whether or not they're eligible, where do they go in their state, sort of serving as a connector, not necessarily as a navigator, but as a connector to the information in their particular state or region, and helping us decide who might be eligible. But most important is what's important to our constituents, I think, and probably to many of yours, is that they should have a list of questions or sort of key points that would be very important to know or ask when they're trying to select the best plan for themselves. So the Arthritis Foundation, through cooperative agreement with some outside funding, released a request for proposal to help us develop this kind of toolkit, and we hope that we'll be able to share that with other organizations. We know we're on a time crunch because the actual enrollment dates start October 1st, so we know that this is sort of a high-pressure situation, but so far so good, and we're continuing to manage and get the information, especially from the National Health Council. So next slide. I was asked to just sort of highlight one, and if you haven't been poking around, the New York Health Benefit Exchange website is really good. I was taking a look at it last night. It'll be a state-run exchange, and a lot of the questions that I've been asking myself, I found that the New York Health Benefit Exchange was sharing information on those exact questions. So I encourage you to take a look at some of the websites that are pretty robust, and I would consider New York to be one of them, and they kind of highlight what the exchange is, what personal information you would even know, and I think even New York goes into eligibility requirements and what's going to happen around October. So the Arthritis Foundation really, really wants to be involved in making sure that we communicate the best and most accurate and maybe easiest information to share with our region so that it gets to our constituents on the ground. Next slide. So that's it. I'm happy to take questions. I'm not sure exactly what organizations are interested in hearing about, but I'm happy to share what we've learned and what we still need to know. Thank you very much.
Excellent. Thank you, Kimberly. And yes, if you have questions, can you put those in the chat window, please? Not in the Q&A window, but the chat window. And we'll take the next 15 or 20 minutes that we have left here to answer some questions. And I guess I have indicated wrong on this panel. We want that in the chat window. I'd like one of the three of you to address just kind of a generic question, because we've talked about exchanges and health benefits, but me personally, I'm on a private health plan. I pay for that every month, and I know a lot of you will probably have health plans through your employers. How do these exchanges work, and how will they change our benefits, or will they at all, versus the plans that we have now?
Sure, I'll take that. So really what these exchanges are designed to do is more for the private insurance plan. It's intended to be a sort of one-stop shopping area for someone who is looking for health insurance on the individual market to be able to sort of navigate a portal of different options that they have and find the one that's right for them. For someone who is getting insurance through their employer, you probably won't see much of a change of how that process goes. But really what the exchanges are looking at more would be for the individual market.
For the individuals that are currently uninsured or those that are currently insured?
For both. If they're currently buying from the individual market, that would be the way that they would now do it. And for people who aren't insured, especially for those who aren't insured because they can't find insurance that will cover them because of the conditions they have, this will create a new marketplace for them to be able to do that.
Okay,
so there will be certain.
Go ahead.
This is Joel White. There will be changes for people with your existing policies if you're a non-grandfathered plan. So certain plans were grandfathered in, and these are typically going to be your large employer plans, and they're increasingly getting rarer and rarer because to the extent that someone shops around for a different plan or makes significant changes to their plan, you switch over into non-grandfathered plan status. So for non-grandfathered plan status and the plans that a lot of folks have, they will have to comply with certain new requirements in the Affordable Care Act, like guarantee issue, guarantee availability, things like that. These are requirements in the individual and small group market. The essential health benefits package does apply both inside and outside the exchange, and there are certain other market rules that apply inside and outside the exchange. Again, the big difference to keep in mind between inside and outside the exchange is inside the exchange you get the subsidy, outside the exchange you don't. But to the extent that your employer is, say, providing insurance in the small group market, some of these new rules will apply to that plan. The implication is that, to the extent that it's requiring better coverage or more robust coverage, it's likely the plan is going to be a little more expensive. For large employers, people with generally with in the ERISA market, so think your IBMs and your Verizons and those types of companies, these rules generally don't apply. But there will be changes for almost everyone, most acutely felt on the premium side.
So just to clarify, on the large group insurance is not covered by these regulations?
They are, so for certain regulations they do apply to ERISA plans, but for most of them they don't. So really a lot of these changes are that are going to impact, that make a major difference in the plans today versus next year, January 1 of next year. The real differences you're going to see are in the individual and to a certain extent the small group market. So for example, in the individual market, if complying with the essential health benefits, one of the big things in the current plans that are typically offered today in the individual market is that they generally either don't cover or have a very skimpy benefit on maternal coverage and for mental and behavioral health. To the extent that those have to now be made more robust to comply with the essential health benefits plan, people will get that access to that better coverage, but they'll also pay for it through a higher premium.
Okay, thank you. We're getting a number of questions here, and I'm going to try and sort through them a little bit. I just need to say that we're not going to be able to answer very, very specific questions about specific circumstances because that would take the rest of the day and then some. We are providing as part of this slide set, which you can download at the Global Genes website, globalgenes.org/webinars. You can get the slide set and you can get the emails for each of the panelists today. One of the questions is directed to Eric. Is there a date or time frame when these benchmark oversights will be completed? It's from Cindy.
Sure, and I can talk a little bit more about timelines, which is something I probably should have mentioned before too, so people realize where we are in the process and what still is yet to happen. The benchmarks have been selected. Right now, depending on what state you're in, that would kind of dictate where they are along the lines of determining whether or not certain health plans that will be sold on the exchanges meet the requirements for essential health benefits. But a lot of that is going on right now, and in some states they've already determined this. So it kind of just depends on where you are. But that all should be wrapping up relatively soon. One thing that we kind of didn't mention is that open enrollment on the exchanges will be coming up in October. While it seems like that's a ways off, there's still a lot of work to be done up until then, largely about educating folks about the need to actually enroll. That's something that people who are here from patient organizations who represent various patients, they don't really understand what a health exchange is. They don't know that this is where they're going to be now going to buy their health insurance and that there is insurance available to them now. So that's going to kind of be what a lot of organizations where they should be focusing their efforts. As I mentioned, open enrollment will start October 1, and we'll go through March of next year, and the exchange coverage will start at the beginning of the year. So as I mentioned, it seems like it's really far off, but it's really not, and there's a lot of education and outreach that needs to be done in the meantime.
Another question that's, if I can pull two or three of these together, has to do with drugs specifically for rare diseases. We tend to be on the wrong side of the list in terms of the cost side of those drugs, as well as perhaps how they're provided, and some of them are very, very expensive. Where these drugs are not on the standard formularies, and I can't come up with the word that you used to exactly describe that, but where the drugs are not on those formularies, what are people to do?
So this is something that we want to make sure is absolutely clear in some of the guidance documents, that there be an established process for access to those drugs that are non-formulary based. And we are encouraging people to weigh in, you know, with HHS to ensure that that process is spelled out in a very timely manner. I mean, it's not like people with rare diseases can go without. So there needs to be some kind of an exceptions process to allow people to have access to those products.
And that
I think that most plans do have these. It's just that they're all very different, very complex, and difficult to navigate. So what we're hoping is that this will be done at a more uniform level, so that we're able to educate patients on how they can go about doing this if there's just one process for all plans.
And that process is in a state of definition right now, is that correct? The appeal process?
Yes. Yeah. Well, we're hoping it is, because there could be a decision made that they will just let the plans decide how they want to define medical necessity exceptions and appeals. And we're hopeful this won't be the decision that they'll make.
Okay.
So in other words, in Medicare, for example, there's a very well-established process that beneficiaries go through in appealing coverage decisions or, you know, denials. That process is largely left up, we think, plan by plan in the ACA. And so what we'd like to see is more of a process put around access, so that, you know, patients know that, well, if I'm denied this, I can actually appeal it or go to an independent arbiter, or, you know, perhaps escalate the appeal to an independent entity.
Okay. I want to jump just for a moment to this next slide, if I can get it to go. And this is a letter that you all have, I think all three of you have contributed to, and Global Genes right now has helped facilitating signatures. A letter to HHS regarding the new health benefits and some of these things that we've been talking about. The link to download and review that letter is on the screen. Will also be on the Global Genes website. And we'd encourage all of you to take a look at it. And I would say for two reasons. One, because I think it very succinctly identifies some of these issues that we've been talking about. So it might help you learn a little bit more about it. And number two, particularly those of you in advocacy organizations, you know, representing communities, we would love to have you sign on to this letter. And there's a mechanism to do that as well on the Global Genes website. It's, I don't know, 4 or 5 pages long, and the idea is to provide, to request that Secretary Sebelius provide some clarity in some of these things that we've been talking about. So again, I would encourage you to look into that. A question popped up asking if employers might be able to drop insurance coverage to allow individuals to seek their own insurance through the exchange. And maybe I can broaden that. Would we as an employee have the choice between the employer's insurance or the exchange, or how is that going to work?
Yeah, the employer is subject to the employer mandate if they have more than 50 employees. the employer therefore has to offer affordable coverage, and if they don't and the employee goes to the exchange and receives a subsidy, the employer will be hit with a fine of $3,000 per employee. So there's an incentive for employers to provide the coverage and to make it affordable. If the individual chooses to, if the individual does have access to affordable employer coverage through the employer and chooses to go to the exchange, I think that would be a decision that's made by that individual.
Okay, thank you. Another question came up about what's going to happen with out-of-network coverage, and I think that was addressed early on. Perhaps it was you, Joel. Currently most insurance plans have a higher benefit for in-network and a lower benefit for out-of-network. Will those out-of-network benefits be going away completely, or what will happen there?
This is Joel again. So the out-of-network will continue to remain an option. Plans use that to expand their reach and ensure they're providing services that they may not cover in-network. The problem with out-of-network is that, again, anything that you spend out of pocket in the out-of-network doesn't count against the out-of-pocket limit. So for someone, again, with a rare disease who's seeing someone out-of-network, a specialist, on a regular basis, all of that spending could be unlimited because it doesn't count against that cap. And that's going to be a real problem for people, particularly with serious conditions, chronic conditions, rare conditions, who end up seeing a lot of out-of-network specialists.
So is the law worded that it can't count against that cap, and it's an insurance, or is it an insurance company decision as to whether they want it to count against that cap?
No, it's in the final regulation.
That it can't count.
That it does not count. That's right.
Okay, interesting. Can you speak, or one of you, I think might be Eric, might be best, about preventative care? Are there things that are going to be required in insurance? It's one of those 10 essential benefits that is more in the preventative area?
Yeah, and that I definitely can. That's one of the things that will be required under essential health benefits. I think that was really one of the big themes of the Affordable Care Act, is really encouraging people to seek preventative care and for providers to provide preventative care. I know that one of the things that came into effect very early on after passage of the law, and probably the first thing that I took advantage of once it passed was a free wellness visit every year that insurance providers are not allowed to pay for. So there certainly are a lot of provisions in the law that are encouraging earlier preventative care.
Thank you, Eric. I want to thank all of the panelists, and just in a quick summary closing slide here, remind those of you that have attended of a couple of things. One, this webinar, the recording of it will be online sometime in the next few days, but certainly by next week. The slide set's available on the Global Genes website. We'd love for you to sign on to this Essential Health Benefits letter, which we had on the previous screen. Carrie at Global Genes Project certainly can answer any additional questions you have. We have an upcoming registry in middle of July on understanding registries. We'd love for you to participate in that. And there are a couple of dates that are kind of remind the date things there as well. But with that, I'd like to really thank our panelists. I know that we really couldn't get into a lot of detail here. Their emails are in the slide set, and we would love for you to reach out, if you can, reach out to the panelists specifically, join in their efforts to continue to influence this policy. As Kimberly said and shared with us, it is important that we're engaged and we are able to change policy. And as a rare disease community, it's really important that we stand together on a number of these issues. So with that, it's 12 o'clock. We're going to sign off. Thank you for joining us.
Great. Thank you.
Thank you.
Thanks, Dean.
appreciate you coming on as the panelists. I think this is valuable and insightful, and hopefully we can get some more people along on the battle.
That's good.